Thank you all for joining NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring our neuropsychologists, Dr. Laura Jansons, Dr. Skip Hrin, and neurofeedback legend, Jay Gunkelman. This is an all-star cast that are more than happy to share their knowledge with you. You can find Dr. Laura at Jansons.com. Dr. Skip can be found at drskiphrin.com. And Jay Gunkelman, well, there's only one Jay Gunkelman on Google. You'll find him easy. Please give us 5 stars on Apple Podcasts. It really helps get the word out. If they can't hear us, we can't help them. My name is Pete, and today we're going to answer a listener question, and then we're going to talk about Elon Musk making a little announcement on Saturday Night Live a few nights ago. So let's see. Let me do that again. My name is Pete, and today we're going to answer listener questions. And with Elon Musk doing Saturday Night Live the other night, he announced he had Asperger's. What is Asperger's, and how can we detect it and train it? Okay, everybody, let's get to the listener question. It's a Mental Health Awareness Month, and we have a listener question regarding concussion protocols and using EEG. Or is it a QEEG? If an athlete gets a QEEG baseline and then they sustain a head injury, what would the process be to determine whether they are healthy enough to play? Could it be done immediately, or does it have to be a certain number of days after the injury so the brain mapping will accurately reflect the injury? Okay, who wants to start?
Happy to jump in. But I tend to step all over everything in my life. So if somebody's got something, feel free to just wave, and
go ahead, Jay.
I'll shut up. Traumatic brain injury comes in a wide variety of flavors. Basically, you can have a severe injury where there's white matter involvement and potentially even a bleed. And occasionally, the very severe injuries can induce paroxysmal or epileptiform activity. A contusion, for instance, can create that. So if it's a severe injury, there's reasons to do testing early. Mild traumatic brain injury is generally gray matter. Severe injuries include white matter, which is deeper in the brain. So there's no hard and fast rule, you got to wait a week or you got to do it immediately. It depends upon the severity. If it's very severe, getting it done earlier ends up giving you information that may end up helping change the course of treatment. Obviously, if you identify a paroxysmal discharge after a significant brain injury, there's the ability to actually temporarily treat it with an anticonvulsant prophylactically to avoid the onset of seizures. Every time the discharge happens, it's easier to make the discharge. So quieting it down allows it to slowly fade away as opposed to burn itself in. So an early test for a severe injury is warranted. Now, the EEG, QEEG is a resting state, eyes open, eyes closed task. It doesn't really test the brain on task, doing something. Those are done with something other than just the resting state EEG. The resting state EEG done, 3, 4, 5 days a week after the traumatic brain injury will end up identifying whether there's substantial changes. You want the person to recover some. After a head injury, rest is one of the major things that's warranted. If you put a brain back online too early, it can actually create further damage. The brain requiring blood flow for function when it should be healing is a mistake. So getting the initial study, if it's a severe one, waiting a little bit until it's convenient if it's a more mild traumatic brain injury. But I think auxiliary testing for performance, how does the brain handle a task, is also extremely useful. Continuous performance tasks, which aren't really continuous, they're episodic, but nevertheless, they're called continuous performance tasks, where you're responding to a stimulus. If a 1 pops up, you hit a button. If an O pops up, you don't, that sort of a thing. Well, a CPT task can end up being performed while the EEG is being recorded, and you get what's called an event-related potential. And the event-related potential literally can watch how the brain processes the stimulus, how it engages the motor system, how it disengages the motor system, and also how the anterior cingulate compares the behavior to the model of how the brain is thinking it should be behaving. And you can sometimes see obsessive compulsive or OCD, ODD type things with the anterior cingulate. So looking at the brain at rest is useful. Doing it early for a severe injury, waiting a little bit for a less severe injury, and then again, pairing it with a CPT task. Now, if you've already done a CPT task and have a baseline EEG, you have a pretty good idea how many omission errors, how many commission errors, what the reaction time is, how much variability there is in the reaction time. So you actually have a baseline performance, not just what the resting state of the brain is like, but actually what the behavioral performance is like. And until you can match your pre-trauma behavioral performance, you should think about sitting on the sidelines until you return to functional integrity. So that's kind of a quick rundown. The brain can show lots of different things. There's actually an increase in gamma activity with a significant head injury. And Harry Karasidis is a neurologist who has a focus on head trauma and sports in his practice. And he coined the term BAMA for traumatically induced gamma, BAMA. It's kind of descriptive. You get a whack in the head and you end up with an increase in gamma. But a slow focus is there if it's a more severe injury, if there's white matter, and changes in alpha and beta are there if there's gray matter. Anyway, that's a quick buzz through the territory, and I want to leave it open for others to comment as well.
Can I, before the others get in there, like when I played ball, I would take a good hit on the field, and I remember the docs doing something with their finger. And what is the protocol now to like, what is severe? Because I remember guys would get back in the huddle, they didn't know where they were, but they still performed. They finish out the game. They don't remember the rest of the game. I guess that would be severe. But
yeah, that's a pretty significant head injury, all right. If you get hit enough so that you don't know where you are, if you're walking towards the wrong end of the field, if there's an alteration of consciousness where you're temporarily out of awareness at all, the person who's still laying there on the field after a head injury. Nowadays, the protocols are if they see you hit, whether you're complaining or not, they usually pull you to the side and do some quick testing. Now, tracking the finger with your eyes is, you've got to be somewhat intact in the frontal lobe for your eyes to track things. So they're not really trying to see if you can see the direction of the E on the chart. They're just trying to see, are your eyes pointing in the same direction at the same time, kind of. So it's a gross test. That they sometimes would test things like balance or something, but the CPT task is a little handheld computer thing that you operate. You hit the button when you get the right signal, and that kind of a screening ends up being quite objective. And again, it tests for omission. Are you missing signals where you should have hit the button? Commission errors where you're hitting the button when you shouldn't even think about hitting the button. And what's your reaction time? Are you taking twice as long to hit the button? Oh, geez, am I supposed to hit the button here or not? And then variability in your reaction time. People that have paroxysmal discharges induced from head trauma will have tremendous variability in their reaction time. Anyway, we've got other comments here too.
Yeah, so you get the CPT test. It sounds like that's going to be one where you do need a pre-test, because if you don't know if they have a normal premorbid, and if they got ADHD or something weird, that's going to jack up the CPT test. So you definitely need a pre-test on that one. And so Pete's question, well, I mean, when I'm thinking of that, it's like, so almost what's the point of the QEEG if you already got the CPT? I know here in Chicago, the local high schools, they give a like a baseline testing where it's, working memory, you get the digit span, you have to, read digits and have the person read them back to you and then do some operations with them, say them backwards, say them in sequential order. That's one of the tests. And I think they do like a trails type thing where they're measuring dorsal attention, ventral attention, where are the numbers located in this connect the dots thing? And can I sequence things in the proper order? And then can I flexibly switch back and forth in sequence? So yeah, a lot of frontal lobe type tasks, frontal striatal, thalamic loopy kinds of tasks. But, talking about the CBT, certainly frontal and the frontal thalamic loops. So, back to Pete's question and the question of the caller, what is the point of a QEEG pretest, and would that be something you would recommend?
In fact, the EEG pretest, you don't necessarily have to process it out. You've got a baseline recording. And if there is a head injury, you've got a baseline study that you can then process out and compare to a more current study. So you can save yourself a lot of essentially cost by just doing the recordings as a baseline, set them aside in an archive, and then pull them out if you need them for a comparison. One of the things that we see basically is that mild traumatic brain injuries, the concussion, where it's not a severe injury, there's no bleed, there's no contusion, the person operates just fine on the short run, but the connectivity has been altered in gray matter, and gray matter networks end up being sometimes fairly subtle. So you may pass a lot of those, but the mild traumatic brain injury, not the severe one, but the mild traumatic brain injury may go undetected in routine screening. The EEG is very sensitive, not specific, but very sensitive to ischemic cerebrovascular changes. And if you get a concussion, it's, when you're little, your brother or some guy in the neighborhood probably slugged you in the shoulder playfully, and your shoulder will swell up a little bit from getting whacked. And when you whack your brain, it swells up a little bit too, but it can't swell out like a shoulder can. So it compresses the blood vessels in the area, and you get cerebrovascular ischemia in the area where the pressure is. And that basically is identifiable in the EEG. The slow edge of alpha tracks ischemia. So you can actually see, oh, well, the brain did suffer a very minor insult over here. And it's going to take some time to fix that. The brain regulates its own blood supply based on function. If you turn an area on, that area opens up blood flow to the area. Well, if you turn on an area that's got ischemia and you exceed the compromised capacity to flow to the area, you're going to actually create problems. But if you turn it on very gently, it'll slowly open up, and you'll end up repairing the ischemia. Neurofeedback, gently training an area to activate, not beta training or gamma, fast, very, very active function, but very gentle activation. The sensory motor rhythm frequency band is the fast edge of alpha, 12 to 15 hertz, outside of what normal people think of as alpha. But in neurology, 11 to 16 is called fast alpha. So, and it's in that range. So it's a neutral positive perfusion. It's above the mean, but it's not 2 or 3 standard deviations above the mean. It's a very gentle on position. And that type of training can open up areas of ischemia so that function can return. If you don't treat the area, it can end up with a chronic ischemia. they don't just spontaneously recover, they recover due to careful, gentle function. If you've actually gotten a concussion and the brain is swelled, you need to carefully put that area back online. If you push it too hard, the compromised blood flow will end up with downstream hypoxia. Hypoxia creates edema. Edema creates pressure, which makes the ischemia worse. You can actually create cell death by pushing an area too hard too soon, which is one of the reasons they tell you to rest after head injury. So the EEG baseline can be used to identify whether the slow edge of alpha has appeared somewhere. Normally your alpha might be 8 to 12, kind of an ideal Goldilocks alpha peak in the back of the head somewhere. But if you look around and you see the alpha peak somewhere suddenly has a bulge on the slower edge to it, you've got an area that's likely compromised. You can do some gentle training in the area and put it back online. If you identify an area that's got significant ischemia, there's also hyperbaric, which is very useful for ischemia. There's other forms of training, not just neurofeedback, to gently put the area back online. But if you don't identify the problem, it's hard to target it. You can't tell by, oh, I got hit here. Well, it doesn't mean the damage is there. The brain flops all over the place in there and it hits somewhere, and that's where the problem is. Now, it's not uncommon to have it at the location of the trauma, but you can have it at a distance as well.
Yeah, so that gets into my comment, I guess, is that these pre-tests they have at the high school I just mentioned, so the trail is kind of a connect the dots thing, and the digit span, how many digits can you hold in your mind at once and perform operations with them. Those are largely frontal tasks. Even the CPT is largely frontal. And that doesn't mean, you didn't get hit in the back or the side or other places.
Actually, the event-related potential, which is a CPT with the EEG recorded during it, and then for every presentation of the stimulus, you end up time locking the EEG to that, and the average EEG drops out, but the response to the stimulus adds up. So you do 100 stimuli, and you've got a very reliable signal. That signal includes sensory detection. I mean, did you actually see the thing that popped up in front of you telling you to hit the button or not? It shows you the processing, the ventral and dorsal processing stream. What is it that I just saw? Where was it that I just saw it? The motor engagement, the motor inhibition, and then the comparison of what you just did to the model of what you think you should have been doing, which is in the anterior cingulate. Each one of those steps is part of the processing of that stimulus and the response. And again, if you record the EEG during the CPT task, you don't just get the behavioral output. I've actually seen the behavioral output be acceptably okay within normal range for the person's age. But when you actually look at the brain's processing of it, you can identify a component, the breaking down of that event-related potential. Usually they call it a P300, where 300 milliseconds after the presentation of the stimulus, you can differentiate what the stimulus was and respond to it. Well, that's a pretty gross waveform, and you're looking for it somewhere in the parietal area about 300 milliseconds later. Well, that's picking that peak and that latency is a very gross measurement. Nowadays, they do independent component deconstruction of the ERP into the pieces that make it up: sensory detection, sensory processing, motor engagement, motor inhibition, and anterior cingulate comparison to the model that you think you should have been doing. And that's tremendous detail. And there's actually, if you're using a system that has the norms for that kind of a performance already in the database, the Europeans and the Koreans have norms for the visual continuous performance task. And it's a very, very sensitive task. It's not just frontal. It's not just memory temporal. It detects visual detection, parietal temporal processing, motor engagement. Motor engagement happens just before motor inhibition. You actually have to kind of think about starting the response before you stop the response. And the detail of all that timing and everything is wonderful work. Yuri Kropotov received the Russian Prize for Science for using ICA on ERP and EEG after I introduced him to the ICA when we lectured together in Portugal. So it goes back quite a long ways now to the 2001 when he was kind of handed the tool. Now, I can't claim anything on that. I handed them tool thinking that the ICA was a way to take out artifact, and he saw that it was a way to see meaningful components. So yeah, he's the brilliant one here. I just stumbled onto this tool and handed it to him, you know. So he's the real neuroscientist in this.
So the short answer, I guess, is that QEEG or EEG as a baseline is far superior to the short little tasks that they're giving now to the frontal trails and the digit spans, and those little baseline things are nothing in comparison to doing the cues and doing it with the event potential with the CPT.
Yeah, an event-related potential with the CPT ends up being a superior form of assessment. And it's one of the reasons I recommend it. I think it tests a lot of different capacities. You're not going to get away with a right temporal or a left temporal. I mean, the two processing streams are both tested separately. It's an advanced form of evaluation. And we use it clinically, not only diagnostically for ADD, but we also look at it for pre-post on traumatic brain injury. And I think that's a very, very powerful application for it.
Yeah, and to simplify it even more, you know, we've got parents listening and such, that the tests that are given now as a baseline are very minimal, only testing very small, you know, fraction, well, not that small, but a fraction of the brain functioning is missing out on all the other areas of the brain that could be damaged or hit.
I have to say that their crude examination is probably going to catch the really severe injuries where the brain has had a contusion, there's an introduction of an epileptiform discharge, there's a major bleed. Those kind of things are probably going to get caught on their crude screening, but they're going to be missing the subtleties of the concussion. Now, they do say that 90% of the people with concussion recover, quote, spontaneously in about 6 months. Spontaneous recovery, I don't know. You've done things to recover, but there's also things you could do badly and mess up your recovery. So I think the assessment of subtle findings ends up helping to guide us to avoid putting an area back online when it still really needs further therapy. And the last thing you want to do is put somebody back on the field when just their physical action, not another hit, which is another matter entirely, but just their physical action may end up overtasking an area and creating cell death. Now, cell death is a really nasty sounding thing, you know. As you're sitting listening to a lecture over a dinner at a meeting, you're killing off a lot of a lot of brain cells with the couple of glasses of wine during the dinner while you listen to a dinner speech. And a dinner speech is never really a great speech, you know. That you don't pull an A card and get assigned to lecture during dinner where all the glasses are clinking and people are chattering, but you know that you're killing off, you know, thousands of brain cells. But the thing is, if you're actually paying attention to the lecture and it's material that you're learning, you're making more connections. And it's not about how many cells you have, it's about how many connections you have. So you haven't gotten stupider by killing off cells from 2 glasses of wine, but you will kill off cells. You just have an improvement in the connectivity. to compensate for the cells.
Jay and Laura and Pete, I had just a question slash, opening for comments too. So we're talking about, you were alluding to maybe more mild hits or injuries, Jay, but the question was about a TBI, and my question, I guess, is about the more subtle hits, and Pete's played and I played, that happen on every play. If you play on the line, an interior position, unless I don't even know how you could avoid hitting on every single play, whereas other positions you might not. And so you have these micro hits that occur 60 times a game at least. So my question, I guess, or comment, what would be appropriate for an assessment of the accumulation of those types of hits? And I'll just lay out an example. So back when I played, you would do a pre-physical and then a post-season physical, and then you had the off-season to rehab shoulder, arm, elbow, knee. Nobody even talked about brains back then unless you fell down and didn't get up, right? But that is, I guess, what I'm wondering, what kind of assessment slash treatment regimen could be established, maybe with a pre-season, pre-test, and then mid-season, post-season, to account for these micro hits that absolutely happen and have effects, right? Yeah. So anyway, there's a question in there somewhere for you guys.
Well, I think previously I said a mild traumatic brain injury and a mild traumatic brain injury don't yield a mild traumatic brain injury. When you add them up, they don't add, they're exponentially multiplying. The second hit may, the brain's creates networks, and networks have spokes and hubs, kind of like a big Tinker Toy set, with the hubs are the little round pieces and the little spokes between them. Now, if you could get a good hit in the head, you might break a couple of those little spokes that go between hubs. And, you can look at the Tinker Toy thing and go, well, I can just go to this one and that one and then back to that one. So I can reroute, no problem. So a mild traumatic brain injury that does one little connectivity thing, you can reroute. But let's say you took out a hub. Well, that's a little harder to reroute. There's a lot of little spokes going to that hub. And some hubs are more important than others. They're called the Rich Club hub. And a Rich Club hub, if you take one of those out, you're down functionally for that really messes you up. If you take out a Rich Club hub, you may not recover well. And one injury and then another injury, you're starting to take out more pieces. The more pieces you take out, the harder it is to reroute and make brain areas connect for purposes that they should be connected for. So multiple hits are not a good thing. Little tiny hits are probably recoverable, but the second or third or fourth tiny hit, you might break enough spokes to end up taking out an entire functional area. And that's the problem. Repeated sports hits. The Thompsons, Michael and Linda Thompson in Canada, Michael passed recently, but their kid, James Thompson, at Penn State, did his PhD dissertation on sports injury and repeated sports injury. Really solid data on the fact that repeated injury ends up being, 1 + 1 isn't 2, it's 10, so those little ones aren't entirely dismissible. Now, there's a big incentive to be on the sports team. You don't want to let down your teammates. Goodness knows everybody that's got whacked in the head and knocked to the ground, and the team doctor rushes out and they start testing their finger, what's going on? Well, you got hit. Well, let me back in the game. I'm fine. It just rang my bell. I just saw stars. I just. Well, the desire to be part of the team, back on the team, not let down your teammates is so strong that people will make really bad decisions and stay on the field. And the little tiny ones that rang your bell, those were probably a time to sit out, maybe take the rest of the game off, maybe just a few minutes to the sideline to clear your head and see, pardon me, whether you can pass simple CPT tasks and things like that. But a brain injury is a brain injury. A mild traumatic brain injury, you can't really judge based on the force whether it was mild. You have to judge based on the effect, what area of the brain was actually impacted.
Yeah, I can't help but still think about last week with Seaburn Fisher, and she talked about those pudding caps from the 1600s, that someone had the theory that, when you're an infant, you bounce around a lot, and, talked about these micro hits. Well, isn't that our childhood, especially during those young developmental stages, and the theory that perhaps, all those little micro hits as a child result in ADHD, all the ADHD we're seeing. So, how is that any different? Certainly different in terms of developmental stages and the fragility of the skull, when you're so young, and all the changes and pruning and things like that. So kind of compelling stuff.
Yeah, and the traumatic brain injury in a young child is still a serious thing to be looking at. However, as you're crawling and your arm collapses and you fall like 6 inches or 8 inches and bonk your nose, we are born with twice the number of brain neuron cells that we end up with as a young teen. Post-puberty, about half of the brain cells. So, and our cortexes aren't really wired up. The networks aren't wired up and myelinated when you're an infant. And your brain is all fresh and puffy. And when you get old and it fades away and it's wrinkly and has lots of space to flop around up there, you have lots of more damage. My father, in his 80s, went back to Fargo for Thanksgiving. He slipped and he fell, and he hurt his shoulder and got a little nick on his eyebrow. And they stitched up the eyebrow and they x-rayed his shoulder and arm, but they didn't CT scan his head. And if you're in your 80s and you fall from, I don't know what he's the Amazing Shrinking Dad at that point. I think he was down to maybe 5'6" or something, and but if you fall from that height, that's not like a baby bonking from a few inches up. That's a serious whack, and the brain flops around in there. I spoke to him on the phone about 5 weeks later. He was in Arizona, back in Sun City, and watching football on a Saturday, and he was looking forward to watching football on Sunday. But I spoke to him, and he couldn't really understand what I was saying fully, and he couldn't find words. And I'm the product of this guy, so he found words before. He was a public speaker if there ever was one. So I realized, oh shoot, my dad probably has a subdural hematoma. If it was an epidural, it would have killed him within hours of the trauma. They would have probably spotted that behaviorally at the time, but they didn't see his head. He had 160 cc's of blood. His left hemisphere was squeezed to the point where there wasn't any convex concave. Oh, wow. It was just absolutely smashed. And I told him he had to go to the ER, and he really couldn't understand me. I said, put Mom on the phone. And I typed in an email describing what I thought it was and where I thought it was. And she took him and that note to the ER. I got a phone call from my mom, and she said that the neurosurgeon wants to speak to you. And so I called the number, and they passed me through to the headset on his head. He wanted to know how you diagnose a subdural hematoma on the phone. And I said, well, you don't. You use an MRI or a CT scan. This is just a parlor trick. I hang out with neuroscience folks, and it was a good guess. He said, it was a good guess. You told me exactly where it was going to be, exactly how big it was, exactly what areas it was involved in. And I said, yeah, but you still use an MRI or a CT scan. It saved his life. And that's a severe injury, but it's also a senior. And again, an infant bonk in their head, goodness knows, we've all probably got pictures of ourselves as a kid with a bruise here or there, maybe even a black eye or something, but those are relatively minor by comparison to the same kind of trauma to an older child. Because again, the brain is all fresh and puffy, and you've got extra neurons there. You can prune a few that you don't really need anyway. So as much as the
Moan, Jay?
Is it just Jay that's locked up?
Yeah.
Okay.
While he's locked up,
You want
we
to go
sum
to,
up. What I want to do is to tell Jay, I think that was the best 2 minutes you ever had. Oh, I think we got shut off again. Oh, he's going to cut off the video. Yeah, cut off the video. Oh,
back. I had to switch, my cable quit. I had to switch to a Wi-Fi hub.
yeah,
Can
no
I
problem.
just
Yeah.
throw in a quick comment, and hopefully, it summarizes everything we talked about, although it's been quite a lot. And that's we're talking about a double-edged sword to some extent, maybe not something that's sharp or harmful, but we're trying to discuss and maybe raise awareness of head injury, because it can happen with conceivably very little force, right? You bump into a door isn't the same as an auto accident where you wake up in the ER or, after being in a coma, right? Those are quite different. But we're also a pretty durable species. And so it's raising awareness, being cognizant of, hey, if you bump your head, a few times, it could have effects. And there's folks that can, talk to you and look at those effects. Us, right? Folks doing neurofeedback and cues and all those kinds of things. But that we're also, again, pretty durable and can manage these things too. So anyway, just want to throw that in there.
So let's wrap this segment out. That was pretty much the whole show. Whoever that listener was, he got the whole show. But for the parents and the coaches out there, if you get a physical every year, you should get an EEG every year, so you have a baseline to compare it to. And if it's not every year, every season, if something happens, yeah, go ahead, Jay.
The EEG is generally stable from year to year to year. There's a developmental trajectory that's pretty aggressive from 2 to 10, but most of your sports injuries that you're talking about aren't necessarily 9, 10-year-olds. Now it can be, but most of what you're talking about is high school and so forth. And at that point, the EEG is fairly stable across time. So your first year is going to be good until 2-3 years later anyway. So
yeah. Well, and then unless you get bonked in the head and you want to compare it.
Yeah.
But if you get bonked in the head, there's a period of time that you have to rest to let the swelling, the blood flow get back to normal. Would you say 2-3 days, 3 to 5 days, a week? Then you would go in to do another.
It's a matter of scheduling it and getting it done. Again, if there's an indication of a severe injury, they're going to treat you acutely. If you're unconscious, if you can't point your eyes in the right direction. I mean, if you're really not functional after a head injury, they're going to test you fairly quickly. And generally, they're going to end up wanting to have an MRI or a CT scan to rule out a bleed. That's their big concern is an acute bleed. An epidural hematoma, that can kill you in hours, and definitely before a couple of days. So, but a subdural hematoma is chronic, and it can last a long time. As was the
let's
case
just
with
say
my father.
we wave a magic wand and the school has a amplifier there to use in a technician. The magic happens. When would you go in? You got bonked. How long would you wait? Obviously, it depends. If they don't know where they are, that's a whole separate issue. But if you're unsure,
assuming no severe injury, if you wait 3 to 5 days, you're fine.
okay.
If it's a mild traumatic brain injury and you're still suffering 3 to 5 days later, it's probably not as minor as you thought it was.
Right.
We've still got all the discussion about Elon Musk, and he's a real headline grabber. But he claims to be an Asperger's case, and that's on the autism spectrum, and that's a whole broad range of presentations. And bless the DSM-5 for calling it a spectrum, but autism ends up ranging from people who can't speak, which obviously the stockholders would wish that Elon Musk might not speak sometimes, but he's fully verbal. There's lots of kinds of findings you can have in autism. 40% to 60% of the autism population have epileptiform discharges, not seizures, but epileptiform discharges. They would do well to be medicated for the discharges so that their brain would function better. A gigantic percentage of them have white matter changes. There's a developmental period during which your brain wires up the white matter. It lays down white matter insulation on the neurons so that they function better. And in autism, there's an overmyelination or undermyelination. And if that happens, then you have slow changes in the EEG, delta content in the EEG. Others have mu, which is a unique mirror neuron related EEG rhythm. It's in the alpha frequency range, generally just a touch faster than the posterior alpha frequency. It's seen generally at C3, C4, but it's also CP3, CP4 for electrode locations. And it basically is there, you see mu when the mirror neuron isn't engaged. And when you're laying down language, face to face with your parents, you hear the ma, 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 pa, 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 da, 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 and you mimic or mirror back those sounds. And eventually the baby learns, oh, mama is over here, papa is over there. And the frontocentral mimicking then gives the information to the temporal lobe where their comprehension happens. So you lay down language function on the left side, and the mirror neuron ends up helping lay down language. Well, when the mirror neuron's turned off or you're not mimicking or mirroring, you see mu. Mu happens in 15% of the normal population and 70% of the autism population. On the right hemisphere, you mimic facial expressions and emotional sounds. And you lay down the ability to have emotional contact with other people, empathy, and the ability to comprehend emotion. And in nonverbal autism, the left hemisphere is involved, and the mirror neuron on the left is usually faulty. In prosodic perception, emotional comprehension, the one on the right is faulty. And Elon Musk is really, he doesn't see the impact of himself on others because he doesn't see others very well. And that's a classic Asperger's autism trait. They tend to not be able to read emotion, read faces. In fact, the right temporoparietal junction that has the spot that ends up comprehending facial expressions is impaired in Asperger's autism. So facial expressions, body language, the emotional tone of speech. Your mother could give you the voice, from across the room, and you knew you were in trouble and you quit doing whatever you're doing. Well, when you can't understand the tone of the voice, then you have to escalate. So the inability to judge your impact on others generally leads to more aggressive interventions. And the location in the electrode locations is, in fact, old nomenclature T6, the right temporoparietal junction. It's now called P8. In the 1010 system, they kind of shifted some numbers and everything around over a decade ago. And they're trying to switch everybody over to the modified nomenclature. And it helps. Journals expect the modified nomenclature now. So T6 or P8. Actually, T6, the old nomenclature, the T was supposed to be for temporal. But if you actually look carefully underneath that T6, you're on the temporoparietal junction on the parietal side of it. So it's got to be a P. It's parietal, So they in 1948-49, when they came up with the old nomenclature for the 1020 system, it was well intended, but the T's, T5, T6 should have been parietal designation, just to be honest about what you're sitting on top of. It still picks up the posterior temporal aspect of the function, but it's actually in the parietal area.
Well, hopefully we adopt that quicker than we did the metric system, right?
Yeah, exactly. Well, I was really excited about switching over to the metric system because it made so damn much sense when I was in junior high, I think it was. I'm past retirement age now, so like how did that go? So,
right, exactly.
Yeah.
So how do you train it? I mean, can Elon Musk is sewing stuff into his head? Can he?
If it's really severe, it would end up with wiring issues from the myelination, and you'd see a slow focus in the temporal area on the right. If it's less than that serious, you may see mu on the right and right temporal parietal junction excess alpha or slow alpha. And at that point, you can actually train it. We have worked with autism spectrum as an application area for a long time now. I've got a publication from 2011 in the Autism Science Digest, which it's not a journal, it's a digest. They invite authors to submit something. They already kind of pre-approve who's got something to put in. They might correct your English or something, but they don't really, they're not editing the science. They don't have scientific reviewers. They basically invite people with content they want. And we describe the various subtypes of, or various findings basically that you could see in the spectrum, even back there before it was called a spectrum. So we actually know that we can train these areas, and the behaviors associated with those areas can normalize. We have a number of people that came in with full-blown autism, the spectrum fully painted, can't speak, can't relate to you, can't look you in the face. It takes time, lots of sessions, but they escape the diagnosis. It's not something you can catch, so it's not something you can cure, but it's a behavioral presentation, and you can change the behavior to the point where you're no longer diagnosable. And we have our experiences that that's entirely possible. It's not quick and easy, but it's entirely possible to have people escape the diagnostic category entirely. You're more likely to escape it if you're what they call a high functioning autism or Asperger's case than if you have a fully mute autistic. You're more likely to come fully clean if you don't have the epileptiform discharges. The epileptiform discharges take quite a while to train away. sometimes 100 training sessions or more for the ones that have epileptiform discharges. And if the discharge that you have doesn't include the motor strip, you don't have a seizure. So neurology is not going to give you an anticonvulsant generally. And in our practice, we actually looked at non-epileptic patients that had epileptiform discharges in the EEG. And if you're not an epileptic, if you're not having seizures, the neurologist is likely to not give you an anticonvulsant. A psychiatrist, on the other hand, yeah, they'll give you an anticonvulsant to try and stabilize your nervous system. So working with a psychiatrist, we looked at non-epileptic patients that have epileptiform discharges, and we recommended the use of an empirical trial and an anticonvulsant. They actually looked at 76 patients that had that recommendation. They looked at the outcome after they gave them an anticonvulsant. 85% of them got clinically better. Only 6% or so got any worse, and that's 5 patients. 3 of the 5 actually just had a rash or a fever and had to stop the anticonvulsant. That they didn't get worse psychiatrically, but having to change medications was one of the things that we identified as something that might be something indicating a worsening. But 85% success. If the future of medicine is individualized or personalized medicine, evidence-based medicine, that's the evidence to personalize the approach. If you see the epileptiform discharges, you should consider stabilizing that brain, whether or not they have seizures. In neurology, a lot of the, quote, normal patterns or normal variants that have epileptiform discharges are simply epileptiform discharges in areas that don't cause seizures, so they choose not to medicate. Benign Rolandic epilepsy, benign occipital epilepsy in adolescents. The benign occipital ones have visual hallucinations, sensory distortions, but they don't have convulsions, so they don't get anticonvulsants. If you actually treat them, you have a better outcome. John Hughes, MD, PhD, epileptologist in Northwestern, did a nice study on benign Rolandic epilepsy, which is not really benign. They just don't have daytime seizures very commonly. And they looked at life outcome. How far did you get in education? What's your income? How are you satisfied with your life, basically? And for life satisfaction, treated versus non-treated, the people that were treated did very much better. The neurologists will look at that same paper and say, well, the treated versus non-treated didn't really have a difference in seizures. Well, they don't have very many seizures in the first place. So that, what kind of a measurement is that? There's no difference in seizure rate, so we won't treat them. Well, better life outcomes. Why don't you treat them? And it's still a controversy within neurology as to whether to treat these, quote, benign patterns or not. I had a course where a neurologist sat in on the course, an epileptologist actually, and he just about bit through his tongue when I was talking about treating benign Rolandic epilepsy, because all of his training has been saying no, 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 no. And, I argued for actually considering it and quoted John Hughes's outcome. Well, I ruined this guy's career. I mean, he quit a very, very active running of a level 5 epilepsy center and took a year sabbatical to go running around learning how to do neurofeedback because he wanted to start to treat his epileptic patients that, you don't want to treat them with an anticonvulsant, but you want to give them something. And so he was going to add in that. While he was on his sabbatical, 2 of his benign Rolandic epilepsy patients died of seizures in their sleep. How benign is that? So, his opinion of benign Rolandic epilepsy has been changed by his experience.
John Hughes is up by us here. I don't know if you're familiar, but it's kind of a side note. He wrote a book on conspiracy and JFK. Are you familiar with that?
Yeah.
Isn't that funny?
Yeah, he's also extremely good with music. He's an old friend of mine. I've known him since the 70s, and when I wrote the book, The Art of Artifacting, he actually wrote the review of it, saying the only problem with the book is how do you get everybody to read it?
Yeah, right. Yeah.
So
So he's in our neighborhood. You know, we're talking about Elon and we're talking about autism spectrum things. And one of Skip and my mentors, he was kind of a co-editor on the Cerebellum Journal, and he talked a lot about the Schmamann research and how cerebellum can be involved in autism and syncing your behavior to real life situations and things like that. And the up and coming research, and I don't know how old it is already, but how, you know, emotional dysregulation is pretty common in autism spectrum. So when I think of Elon Musk and emotional dysregulation, he's probably the poster child of that. But you're talking about seizures, Jay, and I was kind of curious, kind of what your take is on, you know, this emotional dysregulation that could be cerebellum related versus seizure activity, and whether the anticonvulsants would be useful in kids with emotional dysregulation.
if they have epileptiform discharges and they're emotionally dysregulated, an empirical trial on an anticonvulsant is warranted. Convulsion or no convulsion. If you go to a neurologist, unless you're convulsing in some fashion, you'll likely not get it prescribed. If you go to a psychiatrist, they're looking to stabilize your emotional, function, and they'll consider an anticonvulsant. They might try a couple other things first, but they will consider an anticonvulsant, not based on an EEG necessarily, just as one of the next things to try if something else didn't work. The more advanced ones are now looking at the EEG ahead of time as well. The cerebellum has been historically relegated to, it smooths motor function. It keeps you from reaching past what you're looking to reach towards, keeps you from shaking and trembling. It smooths things. It's just a motor thing. It's involved with the basal ganglia, which are involved in motor function. But those basal ganglia are involved in a lot of things that aren't motor function. All of your frontal executive function has basal ganglia interaction. Just your motor regulation, the frontal lobe goes to the head of the caudate, to the putamen, globus pallidus, thalamus, and up to the motor strip. That's your inhibitory loop, and it's how you regulate movement. But the same basal ganglia are involved in emotional regulation and action selection, executive choice. Should I do this? Should I do that? Should I inhibit this or should I excite this? All of those decisions end up being frontal executive function, but the frontal lobe doesn't regulate the brain cortical. It goes cortical, subcortical, thalamocortical, and those subcortical structures are critical. The difficulty in EEG land is that the caudate and putamen and globus pallidus and thalamus are monopoles. They don't generate externally visible EEG. The cerebellum is a monopole. It doesn't generate externally visible EEG. Now, there are people that are saying that they're recording things from the cerebellum.
Sure.
There's not just one person, but there's an extraordinary level of proof that's needed to end up showing that a monopole is generating externally visible signals. If you stick an electrode on the head, you're going to pick up something, but where it's coming from is another matter. And there are a lot of people trying to sharpen the focus on Loretta to see something coming from a non-gray matter source. The author of Loretta, Roberto Pascal Marquis, with the Key Institute for Mind-Brain Studies in Zurich, and now he works in Japan as well, basically suggests that sharpening the focus on Loretta isn't ethical to the mathematical assumptions underlying it. You're going to get a solution, but it may not be the right solution. somewhere in the low resolution solution is the correct solution. It's kind of a fuzzy solution. You've got a bunch of areas to pick from, but the correct answer is in there. If you sharpen the focus, you're going to get an answer, but it may not be the right answer. So the difficulty is, for a given surface pattern, there's virtually an infinite number of subcortical processes that could generate that pattern on the surface. And doing an inverse solution that gives you a solution that's correct, but low resolution, at least you've got a correct solution. Focusing it, you'll get a solution, but may not be correct. So as fancy as some of the algorithmic driven imaging is at this point, there's a lot of validation that still has to be done for me to end up fully accepting that you're seeing monopole activity from an external source.
Bob Thatcher, that phone ringing, it's me. We're going to be asking you to come on the next show.
Actually, Bob's done some fabulous work with respect to traumatic brain injury. For instance, in the 1990s, he did a very nice piece of research. He was congratulated on it by Mark Neuer for adding to the science of traumatic brain injury. He did quantitative EEG and quantitative MRI correlations, showing that gray matter injuries give you alpha and beta changes, and white matter changes give you delta increases, and slow increases. And that observation basically allows the EEG to identify more severe and less severe injuries. So he's done some very good things for the science.
Okay, guys. I want to take a clip here to be able to use to the parents and the coaches. So I'm just trying to, I want to sum up the concussion thing. Tell me if it's right or it's wrong. So for the parents out there and the coaches, the kid that's got their bell rung, if you don't have a baseline or EEG that you started out the season with, please get one. If you have one, your kid gets their bell rung, wait a few days for the brain to stop swelling, get back to blood circulation, and then compare the two and have a neuropsychologist, neurologist look at it. Is that what they should do, guys? Okay, do that. And then depending on the age, you can get a EEG every season or every couple of years. If you haven't had any brain traumas, that's great. But just in case, right? Because they make you get a physical every year to make sure your body's okay, make sure your mind's okay. Is that a fair?
Yeah.
Okay.
And, if a team were to hire an EEG tech with a device to come in and record everybody in the team, you end up just getting the recordings. You don't have to have all of them analyzed until there's a head injury to end up with a baseline being compared. It's a fairly inexpensive procedure. EEG techs moonlight all the time. If they're carrying their own equipment, you can usually get an EEG recorder for $100, $150 a pop for a group. So line them up, cap them up, record 20 minutes of 10 minutes eyes open, 10 minutes eyes closed, and you've got your baseline. The team lined up like that, you can get the entire team screened real quick.
Pardon the pun, peace of mind.
Yes,
Okay. All right. We thank you all for listening to NeuroNoodle's Neurofeedback and Neuropsychology podcast. Dr. Laura can be found at Jansons.com. Dr. Skip can be found at drskiprin.com. Jay Gunkelman, again, there's only one Jay Gunkelman on Google. Idea for a topic, please email Pete at NeuroNoodle.com. Please give us 5 stars on Apple Podcasts. Smash that like button on Facebook, Instagram, and follow us on Twitter. They can't hear us. We can't help them. Cue the non-copyrighted music.